এর মধ্যে কি আছে কিছু না, এখানে আমাদের ডাক্তারের তো আমরা কিন্তু খেতে দেবো, তাই এখানটা রেখে দেবো।
Two, which is maternal, sexual and reproductive health 1. So this session is under theme 1, health service. So now I would like the chair, Professor Dr. Parveen Fatima, to take over the session. Thank you.
Good morning, everybody. I welcome you to this session, and because we are short of time, we have to maintain the time as strictly as possible. I'll request the speakers to be very punctual about their time, and I'm going straight to the session. I'll ask Dr. Carolyn Frost-Wright, MD, and she is a partner from World Health USA, to give her speech on innovative approaches to improve quality of maternal health care. Carolyn Frost-Wright.
Good morning. Thank you for the opportunity to present today. I'm Dr. Caroline Frost-Wright from the United States of America, and this is my colleague, Dr. Jill Devlin. And we, with the chairman of our program, Dr. Hector Terraza, would like to present innovations in improving long-term maternal health status in Bangladesh. High parity, prolonged labor, and poor nutritional status are common in developing countries. These are significant risk factors for uterovaginal prolapse. 1 in 4 women have pelvic floor disorders such as uterovaginal prolapse. Discomfort, constipation, urinary retention, or incontinence are typical symptoms. This is a picture of uterovaginal prolapse. This is a patient that we encountered on our surgical camps in rural Bangladesh. As you can see, the most visible part of the prolapse is the cervix, and the entirety of the uterus is actually outside of the body. You can also see the anterior and posterior vaginal wall. In Bangladesh, vaginal hysterectomy with anterior and posterior vaginal wall repairs are typical treatments available at district hospitals. Unfortunately, 25% of these repairs recur with symptomatic prolapse. We encountered no treatment options for recurrent prolapse at any of the district hospitals that we have visited thus far. There's a significant need for more successful procedures in uterovaginal prolapse repair in Bangladesh. In the United States and Europe, there are 2 treatment options that we use quite consistently for both significant prolapse and for recurrent prolapse. The first of these is a sacrocervicalpexy. This has greater than a 90% long-term success rate. It's considered the gold standard in the U.S. and in Europe. With this surgery, we typically perform a supracervical hysterectomy, which is removal of the uterus, and then attach the cervical stump to the anterior sacral ligament. This is a picture here. It's an abdominal surgery. This is the bladder. We've already taken the uterus out, and this stitch that you see right here is attached to the cervical stump. The sacrum is right here, and we see if this will reach on its own. For some women, the cervix is long enough after we amputate it that it is able to reach without any difficulty. For many women, though, then graft such as a synthetic mesh is used to attach the cervix to the sacrum. And again, you see here, this is the dissection on the sacrum, and there's a ligament on the sacrum that we attach this mesh to. And this is attached to the top of the cervix or the top of the vagina. Once we make this attachment, it supports the apex of the vagina very well, and the symptoms that these women have of constipation and of difficulty with urination typically resolve. One of the things that we stress when we do this operation is to make sure that that attachment is not too tight and that you're able to easily slip a couple of fingers behind that mesh or behind that cervical attachment to make sure that they are able to have the sigmoid removed is a reconstructive procedure where we actually suspend the apex to reconstruct the vagina. Alternatively, another procedure is called a colpoplaesis, and that is virtually a closure of the reduction of the prolapse and then closure of the vagina. Overall, this has over 90% long-term success rate, and it's ideal for advanced prolapse in elderly, non-sexually active females. It also treats recurrent prolapse, and it's a very simple operation. Over the past 3 years, our group from the United States has brought gynecologic surgeons, and we've been to 4 sites here: Jamalapur, Shakira, Shirazganj, and Tangai, having surgical camps at these sites. Approximately 30 cases of prolapse repaired at a 4 to 5 day camp at each site. And by the end of the site, in conjunction with the surgeons there, where one of us will scrub in with them, we show them the techniques, and then they operate on their own. And by the end of the camps, they're operating together with us, just observing if they need assistance. The Bangladesh gynecologic consultants are able to do these surgeries by themselves, and thus able to offer these surgical treatments to their patients when we leave. This is with Dr. Jill showing how to do a colpoplaesis in this picture, and you see there is quite a bit of interest from all the gynae consultants and from the gynae registrars trying to learn this procedure. They did a very good job with this when we were done. So in conclusion, there are reconstructive, the sacrocervical pexy, and obliterative, the colpoplaesis procedures that can be taught to experienced gynae consultants in a 4 to 5 day surgical camp. Knowledge of these procedures and ability to perform by local gynae consultants at district hospitals will improve the long-term health status of women in Bangladesh. Thank you.
Thank you, thank you, Carolyn Faust-Wright. It was a very nice presentation, and really what you are doing for our new gynecologists, I'm really thankful that you are coming over here and teaching them and helping them to develop their own skills. Thank you. The question answer session, if there is anybody who wants to, we can go at the end if we have some time. Okay, thank you. Now our second speaker is Dr. Mashur Rahman. He is the Senior Manager, Nutrition and Population Program, BRAC, Bangladesh. His topic will be on strengthening the health system for maternal, neonatal and child health. I welcome him to present his paper. Thank you.
Good morning, ladies and gentlemen. Actually, I was replacing Dr. Kostov. She was unable to attend the conference, and on behalf of I was presenting the strengthening the health system for maternal, neonatal and child health. So starting with the question, why should we strengthen health system for maternal, neonatal and child health care? And the answer would be the common one is the high number of maternal and child mortality in these part of the Asia, and as well we are also committed to achieve the MDG 4 and 5 by 2015. If you go through the status of Bangladesh, in health status of Bangladesh, we have on track for MDG 5, but yet more than 7,000 mothers are dying every year. Utilization of emergency obstetric and neonatal care service is still low. Inequitable access to health care, especially emergency obstetric care, and there is inadequate knowledge of maternal care services. Keeping these issues in mind, BRAC first started its MSH program in 2005 in one of the poverty-stricken district in rural Nilphamari in 2005, which is subsequently expanded to 12 other districts, reaching a number of 21 million populations by this year, and we are going to expand another 2 districts by this month. And the goal of this project is to decrease maternal, neonatal and child deaths and diseases, particularly among people living in absolute poverty. So what is the operational strategies beyond this huge project? Is development of health human resources, where capacity building is an inbuilt continuous process of the program. Community health workers are trained on technical aspects of maternal, neonatal and child health services. communications and field operations. Community empowerment. Communities are empowered through social mobilization advocacy conducted by BRAC for MSH issues. Service delivered at household level. An extensive network of supervised community health workers providing evidence-based services at the community. Referral system is very much important in referring patients in case of emergencies. So BRAC established referral system by connecting communities with facilities, and public-private partnerships, where partnerships and coordination with healthcare providers and communities are executed through the project to enhance accountability of local health system for better quality health services at community and facility levels. And you can see the 3 cadres of community health workers here. From the top, newborn health worker, second, Shastha Sevika, and the third, Shastha Kurmi, called the NSW, SS, and SKs. They are segregated in 3 cadres as because of their qualifications. The above 2 rows, they are able to read and write, and minimum they have 5 grade educations. And SK, which is the below one, she has completed her secondary school certificate. 3 of them are from the local community. They are well recognized by the families, and they provide household visits each month in each household and provide services at the doorsteps. So how they become trained? An extensive residential and non-residential training program has been designed for health workers to develop their theoretical and practical knowledge with the intention to provide quality services to the community. And the types of training includes the foundation training, monthly refresher training, training on special issues, and then we have a skill bird attendant training for the field-based community health workers. What kind of service they provide actually? The services are categorized in 3 qualities: maternal care, neonatal care, child care. In case of maternal care, they identify pregnant women during their regular household visits, provide anti, intra, and postnatal care, referral of maternal complications, family planning, and post-abortion care. In case of neonatal care, they provide essential newborn care, special care for low birth weight babies, management of birth inspection, detection, referral of neonatal sepsis, and of course, referral of complications. In case of child care, exclusive breastfeeding and complementary feeding, immunization, intake of vitamin A intake where they supplement the government. They refer patients from the community to the facilities where immunization campaign is going on. Community care management of acute respiratory infections and diarrhea, and as well as referral of complications. We also trained our community health workers as community skill birth attendants. They sent to the government recognized institutions for intensive residential 6-month training. Thus they can provide safe delivery at household level. They provide skill attendance at birth, ensure safe motherhood in rural areas, diagnose and manage or make decisions on referral of complications. Currently we have more than 700 community skill birth attendants working in the rural areas. So now I would like to show the innovative active referral system which BRAC has implemented in its project areas to prompt refer complicated cases. Here you can see the pictures of the community health workers. They provide regular household visits, and during the household visits they can identify complications, or during any kind of complications they can call to the community health workers to get services. Once they identify the complicated cases, they can call their supervisors, who is a program organizer as a staff of BRAC. He can generate 3 things. He can call the local ambulance to come to the households and provide take the patients to the hospitals. He can also call to his colleagues who is posted to the hospitals, where he can take the patients, provide medicines, bloods, if necessary, and arrange patients for incoming patients. We have also introduced a pickup point, which is a well-known place to the community, and it acts as a junction between a narrow and a wide road, as because the ambulance you are watching here can't reach to the doorsteps. So it's actually a junction between paved and unpaved road, where from the community, the complicated cases are transferred to the pickup point referral hub by a locally used vehicle, and the ambulance can go to the pickup point at the same time. And from the pickup point, the complicated can promptly referred to the facilities without using any time and promptly. So after getting treatment, the complicated cases referred to the hospitals, and the process is not ended here, just because our community health workers provided follow-up to the patients at the household level, whether she is or he is cured or not. So what kind of achievement so far is get? Here you can see the couple of services for more antenatal care, delivery provided by medical trained provider, and postnatal care within 48 hours. And above all the indicators, we have reached universal level of 90%. But in delivery medical trained provider, we reached 35%, which is a bit slower. So a couple of lessons we have learned from this project, and one of them is the partnership model with the stewardship of the role of the government, as because without the government, the project can't be so successful. The service to the community. There is a key mix of the community health workers, and you have seen the referral system, which is provide services to enhance the complicated referrals. Communities called skilled birth attendants who promptly diagnose and refer complicated cases, and as well conduct safe delivery at household level. Services and facilities, government has taken initiatives to make a local level NSS district plan, which is successful in implementing services. There are 24/7 functional facilities at district and sub-district level working with the teaching hospitals. And last but not the least, I'll talk about the Bangladesh Health Progress, because of the partnerships and effective promote targeting make it achievable of the universal level. Government commitment and leadership, along with the strong partnership with the NGOs, have combined with donor support to health sector for positive results. And another one is innovative practices and approaches by both government and NGOs have enabled a comprehensive pro-poor health focus, particularly practice of poor women and children. That makes us more progressive in these sectors. So thank you very much.
And that wouldn't be sustainable, and that would be the proper utilization of the services. And then you can see from the delivery center, the referral was 30 in 2030, 30%. And whereas in maternity centers, it was only 20%. Gradually it's decreasing because we're scaling up gradually. And lastly, I would say that the fact at the best part of the maternity center, that it shows that the reduction of the referral rates also indicates that the midwives, that we call it partnership midwives, are dealing with complicated cases, so the reduction of the referral rate. And also the referral of the high, whoever are referred, mostly of the major interventions in the referral facilities, that shows that we are appropriately referring the cases. And also rising the demand and willingness of the community, because now patients are coming, both beneficiary and non-beneficiary people are coming. So, and that is, and gradually they're also willing to pay out of pocket. That makes, because the behavior is changing, so it's becoming a sustainable model, we are hoping. And also we have a future plan, and we really hope that we'll also deal with, because now it's only been dealing with maternal care, maybe reproductive health care we can also introduce here, and also family planning methods for long-term, and also IUD insertions. These are also possible here, and we've been starting initially. And also the investigation facilities, because we want to provide a comprehensive care. So for the women in Brack Maternity Center, expanding the investigation facilities, so mother would come and have a comprehensive care here. So thank you all. That was a really fast presentation, and I would wait for the question and answers. Thank you so much.
We have 5 minutes time for questions. Any question from the floor? Any questions? Once we clarify everything.
Okay, 24/7 means 24 hours, 7 days per week. So that means we're open all the time. We never sleep. 24/7.
Video can do what independently?
Midwives, these midwives are the paramedics, and they're trained especially on safe delivery, because when they're recruited, we provide them more trainings, and they can conduct normal vaginal delivery, they can do episiotomy, they can do secondary perinatal care. In case of PPH, they can manage that, PPH management, and also in case of IV fluids, and they're capable of that. And some of the medicines which are only the paramedics are allowed to provide, that they can do. And also they do the ANC and the PNC of the patients.
That midwives came from where?
We recruit the midwives from various places. Some are nurses, from Vanshasta also, from other paramedic trainings, but wherever they're trained, wherever they are here, we give them, I already mentioned that we give them another 1.5 to 8 weeks of training. And also when we started this Brack Maternity Center, because even they learn, they keep on forgetting. So we have a regular refresher training, and again special skill refresher training was taken from the Zipur Maternity Center and the Lamb hospitals. So they memorize and they refresh their memories by learning.